Hello everyone, the topic for discussion now is diagnosis and diagnostic aids. What exactly is the meaning of diagnosis? Diagnosis involves development of a comprehensive database of pertinent information. Now this information should be valuable and this information should be recorded as accurate as possible. This data can be derived by various means like by case history, by clinical examination, by observation of radiographs, by evaluating study models. There are various methods by which this database can be collected. Let us know what is various types of diagnostic aids. The diagnostic aids can broadly be divided into two main categories. That is essential diagnostic aids, supplemental diagnostic aids. Essential diagnostic aids means those diagnostic aids without which we cannot evaluate or we cannot diagnose the case properly. Now these diagnostic aids includes first case history, second clinical examination, third study models, fourth certain type of radiographs, that periapical radiographs, bite-wing radiographs, panoramic radiographs, and the last is nothing but evaluation of facial photographs. Supplemental diagnostic aids includes specialized type of radiographs like cephalometric radiographs, occlusal intraoral films, lateral jaw projections, cone shift techniques, etc. Apart from this comes electromyography, that is EMG, to evaluate the muscle activity. Hand wrist radiographs, endocrine tests, evaluation of basal metabolic rate, diagnostic setup, and finally occlusograms. Now let us know in detail what exactly is the case history. Case history actually consists of evaluating valuable information from the patient or the parent to achieve to a proper diagnosis. Now this case history consists of a number of steps. Let us discuss in detail about these steps. First, coming to evaluation of personal details. What exactly these personal details are it consists of first name, age, sex, address and occupation of the patient. Why we need to record the name of the patient? The name of the patient is very much important because when the patient is communicated by taking his name, the patient usually feels very much happy and usually gets indulged in the talk very easily. So it helps to develop a very good rapport with the between the patient as well as the dentist. Apart from this, name is also required so as to know, so as to maintain the records of the patient and also to have future communication. Now, why the requirement of age? Age is very much important because there are many malocclusions which are usually age related. Particularly, we usually have seen during the mixed dentition stage that there is a transient type of malocclusion called as ugly duckling stage, which is usually seen between 9 to 11 years. So if this, we know usually what is the age of the patient, we can evaluate that the patient is normally running under the ugly duckling stage. And this type of malocclusion we usually again get self-corrected as soon as the canines particularly erupt into the oral cavity. Apart from that, there are, if we know the proper age of the patient, we can even know the eruption status of the patient. We will know which teeth will erupt at what age. So age is also very much important. Now the next question is why sex is important. Evaluation and recording of the correct sex of the patient is also very much important because particularly the growth spurts, that means the time period when the growth of the patient usually is more accelerated is nothing but called as growth spurt. This vary among males and females. Hence, we should even have knowledge about when the growth spurt of the particular sex usually is there. Last is nothing but occupation as well as address. Why evaluation of occupation and address is important? Because with occupation and address we can know the socio-economic status of the patient, and by recording the proper address we can even have communication with the patient, we can even have future appointments. Next, coming to chief complaint. Chief complaint is the thing because this is the complaint with which the patient has actually visited the dental clinic. The chief complaint have to be recorded in the patient's own words, and the dentist must give total attention to the chief complaint of the patient. Like we, being a doctor, might have various goals to achieve in the patient, but the patient might have a separate chief complaint. If it doesn't address the chief complaint of the patient, then the patient usually gets demotivated. So we have to give total focus on the main complaint, that is the chief complaint of the patient. Then we have to go for all other findings. Next, coming to medical history. Proper evaluation of medical history is also very much important because there are many malocclusions which are actually related to underlying systemic conditions of the patient. There are many syndromes like Down syndrome, Klinefelter syndrome, etc. So we have to evaluate the entire medical history of the patient and we should correlate this condition with that of the existing malocclusion. Dental history. We should evaluate how many number of teeth are present in the patient, whether the teeth are in their proper condition, is there any decay, missing teeth, supernumerary teeth. All these things have to be evaluated in the dental history. If the patient is having missing teeth, we have to find out whether the teeth is missing by natural or the patient got it extracted. If the teeth has been got extracted, then what is the reason for the teeth to get extracted? All these teeth will give us very much valuable information, and it has to be evaluated in the dental history. Next, prenatal history. This history can be evaluated from the patient's parents. Prenatal history like condition of the mother during the time of pregnancy, how was the delivery, was it a normal delivery, or was it a cesarean delivery? If it was a forceps delivery, there can be chances the patient might have any TMJ problem. So this has to be evaluated. What is the postnatal history? Postnatal history like any postnatal trauma to the child, any postnatal injuries to the child, any damage to the TMJ, any fall, etc. Or the patient, whether the child is involved in any sort of deleterious habits like thumb sucking, tongue thrusting. These should be evaluated in postnatal history. If the child is indulged in habits, then what is the duration of habits? What is the frequency of habit? All these things have to be evaluated. Family history. Why family history is important? Because there are many malocclusions that usually runs in the families, like particularly class 3 malocclusion, Habsburg jaw. So these type of malocclusions usually have familial predominance. They have to be evaluated in detail. After taking all these histories, now we should enter into general examination of the patient. The general examination of patient consists of height, weight, gait, posture, build. Why height and weight is important? Height will give us an idea whether the child is growing normally or the patient is growing normally or not. Weight will help us to evaluate whether there is normal development or whether the patient is becoming obese or the patient is malnourished. Everything can be evaluated. We should correlate whether for that particular height this much amount of weight is sufficient, or the patient is having excess weight, or the patient is having deficient weight. So height and weight have to be evaluated in detail. Next, coming to gait. What is gait? Gait is nothing but the way the patient walks. The patient must be clearly observed as the patient is entering into the dental office and is sitting. With the gait, we will get very good idea of, because if the gait or if the walk of the patient is abnormal, then this gives us an idea that there is some neuromuscular disorder, there is some discoordination in the muscles. So it has to be evaluated. What is posture? Posture is how the patient stands. If the patient isn't standing properly, then there is some imbalance, and because of this lack of balance, there are many malocclusions which occur because of lack of balance between the dentoskeletal structures also. Next is the build. Now what is the exact build of the patient? Whether this build is divided into 3 categories. It can be aesthetic, athletic, plethoric. Aesthetic is usually those patients who usually have a very thin type of build. These patients who have very thin build usually have very narrow dental arches. Next is athletic. Athletic patients are usually normal. Their jaws are also of normal development only. Next is plethoric. Plethoric type of category usually are more obese type of patients. Their dental arches also will be very wider type when compared to normal dental arches. This was all about general examination. Now let us enter into extraoral examination. First, let us see what is the shape of the head of the patient. Now, evaluation of the shape of the head of the patient will help us to get an idea of the development of the normal dental arches. Now, this is again divided into 3 categories. It can be mesocephalic, dolichocephalic, and brachycephalic. Mesocephalic is normal development of the skull. The diameter will be normal and the arches will also be normal in these patients. Dolichocephalic, they are usually skull which are usually long and narrow type. The arches in these patients are also narrow and usually of less dimensions. Next is brachycephalic, more broader and wider type of skull. You can see even in these figures. And the arches will be corresponding to the type of skull only. More wider and more larger type of arches will be seen. Next, coming to facial form. Facial form is nothing but the shape or the rough form of the face. It is also divided into 3 categories. Mesoprosopic, leptoprosopic, euryprosopic. Mesoprosopic is the normal facial form and arches will also be normal. Leptoprosopic are usually considered as long and narrow faces. Their arches will also be narrow and short. Euryprosopic are broader face patients, more rounded type of face. Arches also will be more squared and broader. Next, coming to assessment of facial symmetry. How facial symmetry will be evaluated is the right and the left side of the face will be compared. Normally, there will be a little bit dissimilarity between the right and left side of the face if we ourselves observe in the mirror. But very frank dissymmetry or asymmetry or very noticeable type of asymmetry can be readily be seen. If it is observed, then the patient must be evaluated in detail by taking various types of radiographs like anterior-posterior views, etc. Facial profile. Evaluation of the profile of the patient is very much important. And the facial profile can be evaluated simply by drawing two lines. First line, here we can see, passes from tip of the forehead, that is glabella, to the under surface of the nose, that is point A, and from point A to the tip of the chin. If these two lines passes straight, it is called as a straight profile. If it produces a convex shape, usually seen in case of class 2 division 1 patients, or it can be a concave profile like seen in case of class 3 patients. Next is facial divergence. This can be evaluated by drawing a simple line passing from tip of the forehead to the tip of the chin. It can be straight, anteriorly divergent, or it can be posteriorly divergent. Assessment of anterior-posterior jaw relationship. Simply with the help of two fingers, index finger and the middle finger, when it is placed at the two jaws, that is just under the tip of the nose and under the lower lip, when it is placed, we can know. If it is straight, it indicates it is a normal jaw relationship. If the index finger gets bent anteriorly, then it indicates that it is a class 2 condition. If the lower jaw is ahead, that is the middle finger is moving anteriorly, then it indicates it is a class 3. Assessment of vertical skeletal relationship. This is evaluated simply with the help of an angle which is formed between Frankfurt horizontal plane and the mandibular plane. Normally, these two lines unite at the occiput. If they unite beyond the occiput, then the angle will be more smaller. This indicates horizontal grower or low angle patients. If the angle is formed or the two lines are uniting much in front of the occiput, then the angle will become more and more wider. It indicates vertical growers and high angle patients. Evaluation of facial proportions. A well balanced and a normal face can be divided into 3 equal thirds with the help of 4 lines. First line passing from the hairline, second line from supraorbital ridge, third line from just below, that is the base of the nose, and fourth line through the chin. And these are divided into equal 1/3, 1/3, 1/3, 1/3. The lower 1/3, in the lower 1/3, again 1/3 of it is occupied by upper lip and the remaining part is occupied by the lower lip and the lower jaw, that is chin. Examination of lips. Examination of lips should be done because there can be 4 different types of lips. It can be either competent lips, it can be incompetent lips, it can be potentially incompetent lips, or it can be averted lips. What are competent lips? These type of lips are normally developed and a normal lip seal can be seen when the patient closes the mouth. In case of incompetent lips, these type of lips usually seen because of hypertrophied lips. Because of lack of proper development of the lip, there exists space between the upper and the lower lip and there isn't the formation of lip seal. The third is the category of potentially incompetent lips. Now this is the condition where lips has developed normally, but because of severe proclination of upper anteriors, the upper and lower lip cannot make a proper lip seal. Last is everted lips. What are everted lips? These are hypertrophied lips, and because of its hypertrophy, lips usually appears to be everted. These are the 4 categories of lips. Next is examination of nose. Nose should be examined in detail. First, size of the nose. Normally, nose occupies 1/3 of the total facial height, that is from the hairline to the tip of the chin. Any deviation from this have to be evaluated. This is the size of the nose. Next is the nasal contour. It can be straight, convex or concave contour. Depending upon the nasal deformity, this usually varies. The last is nothing but nostrils. The size of the nostrils have to be evaluated. Both the nostrils should be symmetrical. And if there is any stenosis and all, usually the patient has a small breathing type of habit. So the nostrils have to be evaluated in detail. Next, coming to examination of chin. Chin is one of the most important aesthetic characteristic of the patient. What has to be evaluated in chin is first the mentolabial sulcus. The mentolabial sulcus is the sulcus which is present just below the lower lip. It is usually more deep in case of class 2 division 1 patients and more shallow in case of bimaxillary protrusion cases. After the evaluation of the mentolabial sulcus, next what is to be evaluated is the chin prominence. Chin prominence have to be seen because in class 3 patients usually chin is more prominent when compared to other type of malocclusions. Next is nasolabial angle. Here we can see this is the angle which is formed between the lower border of the nose and another line which runs from the point of contact of the nose and the lip, and this line passes to the tip of the upper lip. When these two lines contact, they forms an angle. This is called as nasolabial angle. It is usually 110 degrees, but this angle usually gets decreased. That is, it becomes more and more acute as the upper teeth gets more and more proclined, and it becomes more and more obtuse as the upper teeth gets retroclined. So this was all about extraoral examination. Now let us see about intraoral examination. In intraoral examination, first let us see about examination of tongue. Proper examination of tongue should be done. Tongue should be evaluated for its function, also for its size. Because usually if the tongue is, because of some muscular imbalance, if the tongue position is not proper, it will result in the development of various types of malocclusion. One of the most common is the tongue thrust habit. Another thing is size. Normal size of the tongue should be there. If the tongue is very much large in size, that is macroglossia, it will also predispose to development of various types of malocclusions, proclination of teeth, tongue thrust habit, etc. Next is examination of palate. Palate should be evaluated for the presence of any cleft, for the presence of any ulceration. Usually in case of class 2 division 1 malocclusion, as the lower teeth goes and they usually make contact with the anterior palate, usually it results in the development of ulceration. Apart from this, we should even evaluate the palate for the presence of any bulgings, because these bulgings indicate presence of certain impacted tooth inside. So they have to be evaluated. So the palate should be examined in detail. Next is gingiva. Proper position of the mucogingival junction, color of the gingiva, texture of the gingiva, gingival contour have to be observed. Examination of frenal attachment. Both labial frenum as well as the lingual frenum has to be evaluated. Sometimes there can be presence of very thick maxillary labial frenum. Under such circumstances, this will result in the development of midline diastema. So it has to be evaluated. Evaluation have to be done clinically, and also we should perform Blanch test. Blanch test is nothing but when the upper lip is pulled, it will result in blanching of the mucosa at the incisor papillary area. So this has to be evaluated. Next is examination of tonsils and adenoids. Why it is important? Because usually in case of mouth breathing patients, we usually think that it occurs because of any nasal obstruction. But sometimes nasal nose will be normal. Still the patient is having mouth breathing. So we have to evaluate tonsils and adenoids. Sometimes because of enlarged tonsils and adenoids also, patient can develop mouth breathing habit. Assessment of dentition. And this is very much important. How many number of teeth are present? How many teeth are missing? What is the status of dentition? What is the condition of dentition? How many decayed teeth are missing? Supernumerary teeth, missing teeth, any pathologies? Everything has to be evaluated in detail. If required, radiographs should also be advised. So this was all about examination, intraoral, extraoral, clinical examination. Now our case history should not only be confined to this sort of examination, because many malocclusions also occur because of lack of proper balance in the stomatognathic system. So stomatognathic system in detail should be evaluated considering the proper function also. So for functional examination, usually we do this functional examination under the following categories. First is assessment of postural rest position and interocclusal space. What is this postural rest position? Actually, postural rest position is that position of the mandible when the muscles which closes and opens the mandible are at rest. They are at minimum contraction. And at this position, there occurs a small space between the upper and the lower. This is called as interocclusal space. Normal interocclusal space is 3 mm at the canine area. Now, there are various methods to evaluate this postural rest position. It can be phonetic method, command method, and non-command method. What is phonetic method? In case of phonetic method, the patient is asked to say certain words like M, S, Mississippi. Immediately as soon as the patient repeats these words and stop, the interocclusal space is evaluated. This was phonetic method. Another is command method. In case of command method, we usually command or ask the patient to perform certain activities like swallowing, lisping of the lips, licking of the lips, etc. As soon as the patient performs this activity, the interocclusal spaces or interocclusal clearance is evaluated. The third method, first was phonetic method, command method, non-command method. In case of non-command method, we doesn't say patient to perform any activity. Patient is simply observed as he or she is speaking or talking. Patient is also unaware of that we are doing his or her examination. And as soon as the patient stops from talking, we usually evaluate. Evaluate the interocclusal clearance. There are another methods by which the interocclusal clearance can be evaluated directly. It can be direct intraoral method, direct extraoral method, or indirect extraoral method. What is direct intraoral method? Directly we take vernier calipers and at the area of canine in the premolar we measure it. Apart from this, direct extraoral method. This was direct intraoral. Next is direct extraoral. In case of direct extraoral method, we make two markings, one at the tip of the nose and one at the tip of the chin. And first we measure this dimension when the patient is in occlusion, and then even at the rest position. Both of these are evaluated. The difference of this gives the freeway space or interocclusal space. The last is nothing but indirect extraoral method. Here we take two radiographs. First radiograph is taken at rest position. Second radiograph is taken at habitual occlusion. Both are evaluated. The difference gives us the interocclusal space. Next is path of closure. The path of closure, or the way how the patient closes the jaw, should be evaluated in detail. Now, as the patient closes the jaw from rest position to the centric occlusion or habitual occlusion, from rest position to habitual occlusion should be evaluated. Any deviation in the jaw have to be evaluated then in detail. Assessment of respiration. Proper assessment of respiration should be done because many patients usually have mouth breathing habit, which has to be evaluated. Now, how to evaluate this? Generally, humans can be either nasal breathers, oral breathers, or oronasal breathers. So they have to be differentiated. There are various tests are there. First is mirror test. Mouth mirror can be placed at the nostrils and even at the mirror. Wherever fogging comes, it indicates that if the fogging is seen near the nostrils, that indicates the patient is nasal breather. If the fogging is seen near the mouth, it indicates that he or she is the mouth breather. This was mirror test. Next is cotton test. Two cottons can also be placed near the nostrils. If the cottons are in place, it indicates that the patient is, if the cottons gets blown away, it indicates that the patient is nasal breather. If it doesn't get blown away, then it indicates the patient is mouth breather. The third is nothing but water test. In water test, we usually ask the patient to keep water in mouth. If the patient is not a mouth breather, then he can easily keep water in mouth. If the patient is mouth breather, then he or she will feel difficulty in holding the water inside the mouth for more than at least 2 to 3 minutes. Next is examination of TMJ. TMJ has to be evaluated in detail. Inspection, palpation, auscultation. Everything should be done to evaluate any TMJ pathology. Examination of swallowing. Actually, humans goes through two types of swallowing. One is infantile swallow, another is mature swallow. Infantile swallow, as soon as the child is born, he or she usually keeps tongue in between the gum pads. This is nothing but called as infantile swallow. But as soon as the posterior teeth starts erupting, the tongue starts getting contained within the arches itself. This is the mature swallow. If infantile swallow persists, then it will result in thrusting of the tongue in between the upper and the lower jaws. This is nothing but called as tongue thrust habit. So this habit has to be intercepted as early as possible because it will result in development of various types of malocclusions. Next is examination of speech. Proper speech, whether the patient, depending upon the age, have developed normal speech or not. Usually cleft patients have nasal resonance. Okay? Nasal resonance sound can be heard. In case of patients having tongue thrust habit, lisping of various sounds can be heard. It has to be evaluated. So this was all about case history in detail. Now let us know about another diagnostic aid, that is the orthodontic study models. What is these study models? Study models are actually plaster reproduction of teeth and their supporting structures. Orthodontic study models have a number of advantages. Whenever these plaster reproduction of teeth and supporting structures are taken, we can evaluate the dentition and the status of the supporting structures in detail. Occlusion can be evaluated in 3 planes of space. Presence of any pathology, etc. will also get recorded in the impression and it can also be evaluated. It is very important diagnostic tool in educating the patient. We can even maintain the records, pre-treatment records, post-treatment records. This will help in developing proper rapport with the patient. We can even motivate the patient. There are a number of requirements of these study models. What are the ideal requisites of study model? The study model, whenever it is taken, it should be recorded. First impression is taken, so the impression should be very much accurate. It should properly record the teeth and its supporting structure, so that we can get an exact idea of the condition of the condition of the dentition. What are the various parts of these study models? Study models usually have two parts. It is anatomic portion and artistic portion. Anatomic portion is the actual impression which is taken, that is the teeth and the supporting structure. Artistic portion is actually what we build up with the help of a plaster. This artistic portion supports the anatomic portion. Now this is the study model. Here we can see this is the anatomic portion, teeth and the supporting structure, which is usually poured with the help of dental stone or dye stone, and the remaining part is the artistic portion, which is usually made up of plaster of Paris. There are a number of steps involved for developing these study models. First is impression making. Impression making is the main gist. It should be taken very much accurately, because if the impression is not proper, then the study model what we develop will also be not proper. So proper impression making is very much important. Various types of impression materials like alginate impression material or putty materials can be used to get accurate impression. Then disinfecting the impression. After the impression is taken, it should be washed with either running water, or it can even be immersed in biocide solution and then washed. Next, casting the impression. After this, dental stone or dye stone is poured on the impression and it is left so that it can set. Then basing and trimming of the cast. Once the impression is set, this tray is inverted over the plaster of Paris, which is present in the rubber base formers, which are available readily, and it is left undisturbed for 30 to 60 minutes. Once it is over, the tray is removed, and now the trimming of the study model begins. The trimming or the trimming of the study model is a very is a task which requires very much which should be done with very much concentration, because proper trimming of the cast will actually gives a very good beauty to the study models. First, this trimming of the cast is actually divided into a number of steps. First, the base of the mandibular cast should be parallel to its occlusal plane. Now, how to make it parallel to the occlusal plane? Now, this can be done by placing the mandibular cast on a T-shaped rubber frame. With this T-shaped rubber frame, marking is done all over the cast, and then this cast is placed by facing its base towards the trimmer. It is placed, and this trimmer what we are using should have a fine grit carborundum disc. Now with this, when it is placed, it will result in a development of a flat mandibular base of the cast, and this base should be parallel to the occlusal plane. Once the base is parallel to the occlusal plane, the next step is the back of the mandibular cast. The back of the mandibular cast should be perpendicular or 90 degrees to the base of the mandibular cast. This can be achieved by placing the mandibular cast with its back facing towards the trimmer. Care must be taken that at least 5 mm of cast should be present distal to the last erupted tooth. Once the base and the back of the mandibular study model is ready, now the upper and lower study models are placed one above the other and with the backs facing towards the trimmer, and they are placed against this moving carborundum disc. When this is placed like that, even the maxillary cast back will be in flush with that of the mandibular cast back. This was the third step. The next fourth step is even the base of the maxillary cast must be parallel with that of the occlusal plane. At this stage, we can see that mandibular base and the maxillary base both are parallel to the occlusal plane, and mandibular cast back and the maxillary cast back both are 90 degrees to the respective bases. Next, the buccal cuts of the mandibular cast must be at 60 degrees with that of the back of the mandibular cast, 60 degrees with that of the back of the mandibular cast. And these buccal cuts should be prepared at least 5 mm away from the posterior teeth. After the buccal cuts, the anterior portion of the mandibular cast, here we can see these are the buccal cuts of the mandibular cast, we can see at the posterior aspect, and then the anterior portion of the mandibular cast must be rounded. It should be in the form of a curve. Next, coming to the maxillary the buccal cuts over, the anterior portion over. Next is the posterior cuts. The posterior cuts of the mandibular cast should be at an angle of 115 degrees with that of the back of the mandibular cast. Next is the buccal cuts of the maxillary cast. The buccal cuts of the maxillary cast must be at 65 degrees with that of the back of the maxillary cast. Next is basing and trimming of the cast. Now this trimming of the cast is a very meticulous step. It should be done with a lot of care, and trimming is usually done on an electrical trimmer with a medium grit carborundum disc. Now this trimming is actually divided into a number of steps. First, the base of the mandibular cast must be parallel to that of the occlusal plane. This is achieved actually by doing a marker, with the help of a marker. The mandibular cast is inverted over a T-shaped rubber marker and a marking is made all over the cast. After this, it is then inverted over the carborundum, this medium grade carborundum disc, and entire base is trimmed so that the base of the mandibular cast is parallel with that of the occlusal surface. After this, the second step is back of the mandibular cast. The back of the mandibular cast is at 90 degrees with that of the base of the mandibular cast. Now this is achieved by placing the mandibular cast with its back facing towards the carborundum disc in such a way that it becomes 90 degrees with that of the base of the mandibular cast. This was the second step. After that, the maxillary and mandibular cast both are occluded. Here we can see the diagram. Both are occluded and then they are placed against the carborundum disc. With this, both base of the maxillary cast and the base of the mandibular cast will now be in flush with each other. The fourth step will be the base of the maxillary cast should also be parallel with its occlusal plane. After this, now we have two casts, maxillary cast and the mandibular cast. Both bases will be parallel to their occlusal planes and both back of the maxillary cast will be at 90 degrees to its base. Base of the maxillary cast will be parallel to its occlusal plane and the base of the mandibular cast will be parallel to its occlusal plane. After this, now the buccal cuts in the mandibular casts are usually at 60 degrees with that of the back of the mandibular cast. These buccal cuts should be at least 5 to 6 mm away from the teeth. After the buccal cuts, now the anterior portion of the mandibular cast. The anterior portion of the mandibular cast is made rounded in the form of a curve. The third step is the posterior cuts. The posterior cuts of the mandibular cast are at 115 degrees with that of the back of the mandibular cast. Next, coming to the buccal cuts of the maxillary cast. The buccal cuts of the maxillary casts are at 65 degrees with that of the back of the maxillary cast. Next is, this was about the buccal cuts. Next, coming to the anterior cuts. The anterior cuts of the maxillary cast are at 30 degrees with that of the back of the skull. Back of the maxillary cast base. Next, coming to what about the posterior cuts? Development of the posterior cuts in the maxillary cast is very simple. Simply, the maxillary and mandibular casts are occluded and they are placed against the carborundum disc so that the posterior cuts of even the upper and the lower maxillary and mandibular casts are in flush with each other. After this trimming, we usually, if this trimming is done very properly, we usually develop very beautiful maxillary and mandibular study models. Then the next step is polishing. Simply with the help, we can do it with a very mild grit sand paper. We can do trimming and then it has to be soaked in soap water at least for 1 hour. After that, it is removed, it is dried, and with the help of a buff, polishing is done. This will result in a development of very good study models. Next, coming to various types of radiographs which are used in dental practice. Radiographs are very much important because when we see some pathology clinically, we even have to evaluate it even radiographically. So for this, radiographs are taken. Intraoral periapical radiographs. These are very simple type of radiographs and we routinely use in dentistry. There are two techniques by which intraoral periapical radiograph is taken. First is paralleling technique, second is bisecting angle technique. What is paralleling technique? It is most commonly used. Here, the small intraoral film is placed parallel to that of the long axis of the tooth, and the X-ray beam is allowed to pass perpendicular, bisecting both the long axis of the teeth as well as the intraoral film. Second is bisecting angle technique. In bisecting angle technique, the X-ray beam passes or perpendicular to a plane which bisects the angle formed between the teeth as well as the intraoral film. There are a number of uses of this IOPA. First, it helps in evaluating the teeth, both crown as well as the root in detail. Presence of any periapical pathology can be evaluated. Presence of any supernumerary teeth or any other abnormality of the root can be evaluated. Apart from this, we can even know whether there is any pathology, any bony pathology present or any radiolucencies that it can be evaluated. A number of advantages of IOPA is that since it is a single film, it doesn't cause that much extra exposure to the patient, and we can take more than one IOPs also if it is required. But there are certain disadvantages also. The disadvantage include, first, entire dentition cannot be evaluated. Only a single with a single film, one or more, two or maximum 2 to 3 teeth can be evaluated in a single IOPA. Another disadvantage is patient usually feels gag reflex. Whenever these IOPAs, film is placed at the posterior aspect, patient develop gag reflex. These are certain drawbacks or the disadvantages of IOPA. Next is bite wing radiographs. Bite wing radiographs help us to evaluate the coronal portion of the maxillary and mandibular teeth. It helps to evaluate presence of any proximal caries, development of any secondary caries, any what is the status or the condition of the bone, horizontal bone loss or vertical bone loss. Everything can be evaluated with the help of bite wing radiographs. Occlusal radiographs. With a figure only we can see a broader area can be evaluated. Entire maxillary arch, entire mandibular arch can be seen. Presence of any fractures, etc., any pathologies, buccolingual positioning of the teeth, buccolingual inclination of the teeth, this can be evaluated with this. Finally, coming to panoramic radiograph. Panoramic radiograph, also called as orthopantomogram. Here, both maxillary and the mandibular arches can be viewed in a single film. Even including the condyles and the fossa can also be evaluated. There are a number of uses of this orthopantomogram. First, both the arches can be evaluated in a single film. Any presence of pathologies can be evaluated. Any radiolucencies, supernumerary teeth, missing teeth, impacted teeth, malpositioned teeth, ankylosed teeth, everything can be evaluated by taking a single orthopantomogram. There are a number of advantages. Exposure is reduced to the patient because in a single film we are evaluating entire dentition. This is one of the very good advantage. Even since it is an extraoral, patient doesn't find it difficult. Since we have seen in IOPA, film has to be placed inside the oral cavity, patient may develop gag reflex. But here everything is happening extraorally, so patient doesn't feel that much discomfort. But there are certain disadvantages also. First, image is not that much clear, particularly in the anterior area where overlapping or blurring of the image can be seen. The intactness of lamina dura cannot be observed. This advantage can be seen in IOPA where the entire intactness of lamina dura can be seen. Here it is not possible. But we get a rough idea of the entire status of the dentition and its supporting structures. Next, coming to electromyography. What is this electromyography? EMG or electromyography is actually a diagnostic tool which helps to determine the electrical activity in the muscle. Actually, our muscles are provided by means of a number of muscle fibers. Each muscle fiber is supplied by various type of nerve terminals, and each muscle fiber is charged positively outside and negatively inside. So whenever this electromyography is used and whenever a stimulus is given, there is sudden muscle contraction because there is reversal of this charge, that is positive outside, negative inside, gets reversed, and this generates a stimuli. This stimulus is nothing but called as action potential. This action potential is actually recorded with the help of electromyogram, and this electromyogram will display the activity of the muscle in the form of electromyograph or in the form of sound waves. Now, how the procedure is exact? This is the device. This is nothing but electromyogram. It consists of electrodes. Two types of electrodes are there: surface electrodes and needle electrodes. Surface electrodes are usually placed in the superficial muscles, whereas needle electrodes can be placed deep in the muscle, particularly like pterygoid muscle, etc. So when these electrodes are placed, the electrodes record this action potential, carries this information and display it on the electromyogram in the form of either a graph or in the form of sound waves, which are recorded with the help of a tape recorder. There are a number of uses of this EMG. It helps to evaluate the tonicity of the muscle, whether the activity of the muscle is correct or not, particularly in case of hyperactive mentalis activity, or in patients having mouth breathing habit, thumb sucking habit, there is muscle imbalance. These imbalance of the muscles, etc., can be evaluated with the help of this electromyography. This was all about essential diagnostic aids which are most commonly used in dentistry. Thank you.